get started then. My name's Christine. I recognize a few faces from before. Today we're going to talk about total knee replacement versus unicondylar knee replacement. Okay, our goals is to be able to differentiate between the two, identify the precautions for knee replacement patients, and there are a few, and also what exercises they need to be doing, okay? The doctor can replace the knee, but if the patient doesn't do the exercises, the outcome's not going to be good, okay? There's a sign-in sheet and handouts for you. So let's get started with understanding knee replacements, okay? The knee joint is a hinge, okay, just like a door hinge. You got the top part of the hinge and the bottom part of the hinge, okay? Top part of the hinge is this bone here, the femur. Bottom part is the tibia, okay? It bends back and forth, okay? It should only bend in one direction, okay? If it bends in a different direction, something is very, very wrong, okay? So we want to get the knee to bend, and if you bend your own knee, it just slides. It's real easy. There's no friction. And the reason there's no friction, number one, you've got smooth cartilage covering the ends of the bones. You've got fluid that lubricates or oils the knee joint, okay? Everybody here eat chicken? Okay. You take a chicken leg, you finish getting all the good meat off. You notice that nice shiny smooth stuff at the end of the bones, where the thigh meets the drumstick. That's the kind of cartilage I'm talking about. That nice smooth cartilage at the ends of the bones. When that gets worn away is when you get knee pain. Okay? How much it wears away varies from patient to patient. Does it wear away on both sides evenly, or is it just on one side? That's what determines whether the patient gets a total knee replacement or only a unicondylar knee replacement. Unicondylar is not as invasive as a total knee replacement because you're only doing half. You're doing the top and the bottom, but only on one side. Okay? Total knee replacement, you've got worn away on both sides, outside and inside. Okay? So what happens is you have to do a total knee. Now, with the unicondylar replacement, like I said, it's only one side. Okay? Here's the tibia, here's the femur. Okay? As you can see, it's only one-sided. All right? You only have to replace one side. You do have to replace the top part of the tibia and the bottom part of the femur and the tibia here. Okay? And you can see it's not that bad, as opposed to doing a total knee replacement where it would be both sides. Patients do recover quicker from this because it is less invasive. Okay? Total knee replacement on the other side. Okay, so that this has to be peeled back. The femur has to be cleaned up so that it can be prepped for the prosthesis. The tibia actually has to be cut, okay? So it gets cut all the way across. It's prepped with the holes, cement, and the prosthesis. There's a plastic piece that takes the place of the meniscus, that little cushion that everybody has, okay? Once it's all done, you have a total knee replacement. Okay? You can understand why these patients are in pain after surgery. They hurt. You just cut open all 2 bones the major bones in their knee and in their leg. It's gonna hurt, okay? You are gonna have swelling because of that injury to the bone, okay? That's why you need to make sure you medicate your patients with something for pain about 30 minutes before therapy, so that they can actually do the exercises they need. Otherwise, they're in too much pain, okay? If you look at this sheet, it talks about how the cartilage gets worn away. When it gets worn away a little bit, you have a little bit of pain. And a lot of times patients can bear with it until it gets to the point where it's called bone on bone. You've lost the cartilage on the top and you lost the cartilage on the bone, and it's like sandpaper rubbing against sandpaper. It hurts. That's when the decision to do a total knee or a unicondylar knee replacement is made, okay? Depending on how extensive that worn away cartilage will determine if it's a total knee or unicondylar knee, okay? Sometimes it can be from the way the patient walks. They're putting more pressure on one part of the knee than the other. It can be congenital. It can be due to medication. A lot of the HIV medications really wears away the bone and the cartilage. So we'll see a lot of HIV patients with joint replacement. This shows you the pieces involved with the unicondylar replacement. It is less invasive. They do rehab a little quicker because it's only one-sided. Okay? This one shows you the steps involved. They have to prep the area of the femur, clean it up, okay, so they have a good surface to cement the prosthesis to. All right? They have to clean up the tibia, remove the meniscus, and get that area prepped, cemented, and they put the prosthesis in. Okay? With all that being done, surgeon's job is easy. He does that in about 2 hours. Hard part comes afterwards. Okay? Exercises, very important. Okay? They need to be able to bend the knee and straighten it. They need this muscle here, the quadriceps, strong. This is the muscle that pulls the leg forward when you take a step. Okay? This is a muscle that gets very weak after surgery. So if everybody can just take a minute and put their papers down, you're going to try something. Okay? Take one hand, put it on your left thigh, one hand on the right thigh. You can sit. Okay? Now, on the left side, tighten that thigh muscle so you can feel it. Okay? Can you feel it get tight? Now relax. Now do it on the right side. And relax. Those are the muscles, those are the exercises the patients can do when they're in bed. Those are the exercises they can do when they're sitting there watching TV. Okay? Those are the exercises you need to encourage with them. All right? When they're in bed, straight leg raises. They keep the knee straight and they lift it up off the bed. Okay? That's something you can do even sitting down. It's a lot harder to do sitting down than it is in bed. Now, lift the legs so it's off the chair. Yeah. Keeping the knee straight, lift it up. That's another exercise that they need to work on. Remember, getting the legs straight is just as important as getting the knee to bend. Now, when they're sitting in a chair, in the afternoon, in the evenings, give them a towel or a pillowcase. Put it on the floor. Put their foot on the towel or the pillowcase. Have them slide it back and forth. It's a smooth thing that they're not getting friction from because of the towel. And just have them work at sliding that knee back and forth. Okay? About 10 times an hour. That will help keep the knee moving. A lot of people ask about CPM machines. CPM machines are good, but the patient's not doing the work. The machine's doing the work. We want the patient to do the work, okay? And this is one easy way to do it. Again, when they're sitting in the chair watching TV, when they're watching Maury Povich in the afternoon, or their favorite show at night, get them to move it. After they do their exercises, ice them. Ice is very important. Helps control the swelling, helps control the pain, okay? Knee replacement, whether it's unicondylar or total knee, they have precautions. We don't want any twisting of the knee, any heavy impact on the knee. So we don't want them standing and then reaching around like this to try and get something, okay? If they need to get something and they're here and what they want is over there, they have to take the steps to get it and then come back, okay? We don't want any high impact activities, no jumping, okay? So if they ask you, will I be able to play golf after this? Sure, golf is not a problem. Will I be able to play basketball? I don't think so, okay? The younger population may be more interested in the basketball than the older population, but it's something to keep in mind, because you may get younger patients, okay? These exercises we talked about before, the arm exercises, these are important for the patients to be doing on a regular basis because these exercises are going to build up their arm strength. Remember, these patients are coming to you 2 to 3 days after surgery. They're weak, okay? You got to build up that arm strength if you expect them to use a walker. Because when you use a walker, what are you using? You're using your arms, okay? So we want to build up that arm strength, okay? The other set of exercises, unfortunately these chairs don't have it, but when they're sitting up in the chair, they can do chair push-up, okay? Pushing up with their arms, okay? We talked about straight leg raises and quadricep setting. Ankle pumps, important for circulation, so they don't get blood clots, okay? So we've got exercises to build up their strength, exercises for motion, precautions, and the differences between the two types of prosthesis. Any questions about any of it?
What causes water buildup in the knee after the surgery?
The surgery itself.
And how do you prevent it?
You can't. And they're going to have swelling after surgery for up to a year.
So
Yeah.
any of these exercises better than others in
They're all
helping to
important.
minimize?
They're all important. Yeah.
And how often do you recommend putting ice packs on there?
After every therapy session and after every exercise session. So if you're having the patients do some exercises outside of therapy, which you should be doing, okay, because 3 hours a day is not enough. It needs to be continued. Because when the patients go home, they're only going to get therapy 3 times a week. They have to be doing these exercises on their own the other 4 days. So if you get them into a routine of doing these exercises here, it'll carry over when they go home. Okay? So every time they do their exercises, give them a bag of ice for 20 minutes. Okay? Any other questions?
Are there any recommendations in transferring from bed to chair?
Okay, the transfers would be the same. Pivot transfers, you would have them push up off, again, here's that push off with that arm strength. Push off the bed, they stand up, they turn, and sit. You want them to do as much as possible, okay? The more they do, the better they will feel. Because remember, when they go home, they're not taking you with them. okay? They're gonna have to do this on their own. So the more they do, the better it is, okay? You can be there to guide and support and give verbal cues as to what they need to be doing. Scooting to the edge of the bed, bringing your leg down first, pushing off the bed, okay? You don't want to do, if the patient is not able to, is not as strong as they could be, you may want to have two people. One to make sure that the chair is supported, okay? And one to help support the patient. One thing you don't want to do is mess up your body when you transfer. So you want a good base of support, you want to bend your knees, okay? And you want the patient to do as much as they can, okay? Anything else?
When the patient is in bed, is it better for them to have their legs straight or their knees bent?
Straight.
Always.
Always. When they're in bed, do not put a pillow under their knees. Reason for that is, oh, it feels so much better like this. Sure. And then it gets stiff, and they can't straighten it. And then what happens is, they go to try and walk, and they're like this, because they can't straighten their knee. They can't get that full extension needed at this point of the stride, because their knee is permanently bent. And it's so much harder to get them to straighten it after that. So if you need to put something under them, you put it just under the ankle, because that forces the knee straight. Try it at home some night. Take a small towel, like a hand towel, roll it up, put it under your ankle, and nothing under your knee. You'll notice your knee goes automatically down. Okay? Good questions. Any others? You all can tell the difference between the total knee and a unicondylar knee? And the exercises you can be encouraging these people to be doing, even if it isn't therapy time. Okay? Therapy time is any time during the day. Okay?
One last question. You're not a big fan of the machines, but would human intervention, like a passive range of motion, be beneficial?
That should be done by a therapist, okay? We want the patients to do as much as possible, okay? Passive range is somebody else or a machine doing the work. We want the patient to do the work. Okay? That's our goal. Now, other doctors may do things differently. Now, if the patient's not aggressive enough in their therapy and are not compliant with their exercises, they will get to a point where they can't bend their knee far enough. Then we have to take them back to surgery and bend it for them. And that's not pretty. In those instances, they may use a CPM machine because the patient's not doing it for themselves. Okay? Any other questions? All right, there's a survey in the back. Complete it. You can just put it in the back table when you're done.